Today we're going to, so last time we talked about just basic neuropsychological evaluation, and this time I'm going to talk about some of the procedures that we're involved in as neuropsychologists, the Wada procedure and then awake craniotomy, which are probably like two of the coolest things that we really get to do, I think, personally. So first I'm going to talk about the Wada procedure and how it's used, and then we'll talk about a case example. Then I'll discuss awake craniotomy, and then I have a video from last week's case that hopefully we'll get to a little bit of that. So, last time I introduced how neuropsychology is, neuropsychologists see patients with a lot of different neurological conditions, and epilepsy is one of them. I think we touched upon some of the reasons why a neuropsychologist might see an epilepsy patient. But just, discussing it again, when a patient presents with refractory seizures, and I saw that you guys just had Dr. Goodman on, who's an epilepsy surgeon, so he might have touched upon some of this. Patients can have refractory epilepsy, meaning they continue to have seizures even though they're on a host of different medications, sometimes even with certain, other treatment procedures, like certain devices can be implanted in the brain or other parts of the body, or patients can go on various diets. There's a lot of different treatment options, and they can still have seizures. And in that case, sometimes, surgery is really the best route to remove the part of the brain where they believe the seizure is coming from. But it can actually be much more challenging to identify exactly where the seizure is coming from in the brain. And some patients have different types of seizures. So if they have multiple types of seizures, there might be multiple foci in the brain, or sometimes it's just not really clear. So neuropsychologists can help with lateralization, localization of seizure focus using those tests that I talked about last time, using these brain behavior relationship model, where we sort of map, okay, this part of the person's functioning is much weaker than everything else. We think that that's probably the part of the brain that's having the seizures and not functioning as well. We also can do baseline testing and then tracking over time. So if somebody does have surgery, it's important to track them over time and see if there's any changes. Also just to identify strengths and weaknesses. If the patient is younger and still in school, we can talk to them about where their strengths and weaknesses are. And then, mood and psychological distress. Depression is actually a symptom of epilepsy. So it's very common that patients present with psychiatric sequelae. So it's also, the evaluation can be useful in identifying those types of issues as well. So briefly, the history of the Wada procedure. So everybody sort of refers to it as the Wada, but it's officially called the intracarotid sodium amobarbital procedure. And it was coined by Dr. Wada, who was an epileptologist who developed this technique, many years ago. He sort of initiated it during his residency in Japan just after World War II. And he published a description of motor sensory language and the effects on the conscious state in 1949, first in Japanese, and then he did a fellowship in Montreal, and he introduced the test to the English-speaking world. So here is a couple of pictures, sort of what the Wada test looks like. So patients lying, you can see there's, catheter, there's somebody writing things down. This might be actually this is probably the neuropsychologist presenting objects, and I'm going to go over everything. You see the EEG cap. This is probably a neurologist testing motor strength, and we'll get to all the details on that. So what's actually done in the Wada? So a barbiturate is injected into one of the internal carotid arteries via cannula or catheter from the femoral artery, and the drug is injected into one hemisphere at a time. So either the right or the left internal carotid artery. If the left carotid artery is injected, then that means the left hemisphere functions are inhibited. And also that part of the brain cannot communicate with the right hemisphere. We typically inject the side of the lesion, meaning the seizure focus, or, you know, if it's a tumor case where the, you know, the side of the tumor, to test the contralateral hemisphere, so meaning the opposite hemisphere's function. So for example, if we're saying that the patient, let's say, has a tumor in the left, we want to knock out that hemisphere to see what would happen if we removed that hemisphere or removed part of that hemisphere. Would the other hemisphere, would the right hemisphere be able to function without that other hemisphere? And as you saw in that picture, usually we have an EEG recording at the same time to confirm that the injected side of the brain is inactive, because sometimes people can have, you know, anomalies in their anatomy, and, you know, sometimes, you know, the internal carotid artery can sort of have branches, and it can sometimes end up not, you know, really putting to sleep the hemisphere that you want. So you have to sort of make sure both clinically and electrographically that the hemisphere that you want to be asleep is sleeping, because if it's not, then the data that you get is inaccurate. So usually the neurologist stands on the contralateral side to the hemisphere that's being injected. So again, if the left hemisphere is being injected, they would stand on the right hemisphere, because the left side is going to go to sleep. So the left, sorry, so now I'm confusing myself. So if you're putting the left function to sleep, but the right motor will be what goes to sleep. So the neurologist is standing on the right side to make sure when we inject the left hemisphere that in fact the right motor function is weak. And then we're also looking at the EEG. And then the neuropsychologist usually stands on the ipsilateral side, just to make it, you know, sort of easier for the neurologist to test motor functioning on the opposite side. And if you guys have any questions, you can, yeah, so so a question is, how do neurologists make sure that none of the barbiturate diffuses across the other side? So that's why we have the EEG, because we can look at electrographic, you know, functioning of the brain and make sure that only one hemisphere is asleep. So that's why I mentioned that. And also, you're usually the patient will have both of their arms raised, which I'm getting to now, and then you'll see that, let's say again we're knocking out the left hemisphere. The right arm will suddenly come down, the left arm will be able to stay up. So you have them start counting and you see a motor change, and then the neurologist is sort of having the patient squeeze both sides. So they see, you know, motor wise, there's that lateralization, and also on the EEG. Someone asked, how long does the barbiturate suppress brain function? I'll sort of get to that, but we typically try to get everything into the patient within the first 3 minutes. And then everybody comes back to their baseline at a different rate, but it's usually within about 10 minutes from the initial injection that they're back to their baseline. And somebody asked, the left carotid artery supplies the left hemisphere of the brain? Yes. Okay, so as I said, the patient raises both of their arms, and they're asked to count out loud as the barbiturate is being injected. Once the medication appears to take effect, you'll see, for example, if we're injecting, again, the left hemisphere, you'll see the right hand suddenly fall down, and then we'll say, squeeze, squeeze, and they will not be able to squeeze. In 95% of right-handers and 85% of left-handers, language is on the left hemisphere, okay? That's usually the dominant hemisphere. So usually if we're injecting the left hemisphere, we expect that language will also go. So they'll be counting, and then all of a sudden, as the right hand drops, you'll also see the clinical effects in terms of language. So they'll be counting 1, 2, 3, 4, the, and their speech becomes jumbled and they can't speak. And so we can tell that the medication has begun to take effect. So this is sort of a little bit of like a complicated concept, but we're always testing the contralateral side memory and the ipsilateral side language when we think about it. So what that means, just very briefly, not to go into how to analyze all the test results, but for example, when you think about it, if you're knocking out the left hemisphere, right, and then the patient can't speak, that basically is telling you that the language is there. So you're testing ipsilateral side language. But when you're actually doing the memory testing, you're testing the side that's awake to see if that side has any memory ability in it. So when you're talking about the memory functions, then you're actually talking about the contralateral side. Okay, so the neuropsychologist will first assess language and learning. So we do sentence repetition that becomes more challenging. So first it's very basic, and then a little bit more challenging to see if they're able to repeat. So that's sort of just basic repetition. We do basic comprehension as well. So we ask them to touch certain objects or point to certain objects. And then we also have them name objects and pictures that we present to them. So, so we do a few, we test a few aspects of language. And then the latter, so the naming of objects and pictures, is actually part of the memory testing that I'll get to, which follows the delay. So when you're presenting the objects and pictures to them, you're telling them to also try to remember these objects and pictures. And we actually do a pre-WADA where we go over the testing with them so that they sort of know what to expect a little bit. And then the initial testing portion must be done before the effects of the medication begin to wear off. So that's, usually we try to get it in under 3 minutes, presentation of everything. And the neurologist continues to check motor strain throughout. He'll sort of say, now patient's at 3 out of 5, or now they're back to their baseline. So we kind of are monitoring the whole time how much that hemisphere is really, asleep, and then when it starts to come back to normal functioning. So the whole time we're sort of monitoring that, we're taking notes about it to make sure that we're really testing what we sought out to, which is one hemisphere functioning. So once the first part of the testing is complete, that language testing and the presentation of the objects for the memory testing, then there's a 10-minute delay to make sure that the effects of the medication have really subsided, allow the patient to return to their baseline, and then provide a brief delay for the memory testing. So they kind of, imagine if you're doing the initial presentation of everything 3 minutes, then usually have about 7 minutes where they're just kind of sitting there. You can talk to them a little bit. If they got any items wrong initially, not from the memory testing, but from the language testing, you can go back and re-ask them. I always do that to make sure they're back to their baseline. As I said, we're doing baseline testing with them without any effects of medication. So we know that at their baseline, they can do these brief sentence repetitions and these little comprehension items, etc. So, we kind of, can judge when they're back. And obviously they're also looking at the EEG and telling us, everything's looking normal now. And then the neurologist will retest motor strength. The neuropsychologist will retest basic language skills and make sure that, especially if you're injecting the left hemisphere, like they can't even say their name. So, I'll just, even as they're starting to come back, I'll say, what's your name? And once they can start to say their name, then I'll start to do some other testing, make sure that they're back to their baseline. Then I usually give like a few awareness questions. So I ask them if they have any understanding that they were given the medication. Most patients say no, that they actually don't have any recollection for being given the medication. I ask them if they remembered having any trouble speaking, or if they had weakness on either side of their body. Sometimes they say no, sometimes they say yes. It's just sort of to see if they had any awareness of what was going on. And then we do like a free spontaneous recall. We ask them if they remember seeing any objects or pictures. And usually they can't provide any spontaneously. So someone asked, in people with diseases such as Prader-Willi syndrome that causes medication to delay, you do this procedure, and what would you do differently? I don't know exactly how someone with Prader-Willi would respond to barbiturate if they would need more medication. Some patients need more medication. So I'm not sure. I've never done a WADA with a patient with Prader-Willi, but it's an interesting question. I'm not sure. But certain patients, just require more medication based on just a number of different factors. Can the patient opt to have a family member present if they're uncomfortable? So we really don't allow family members to be in the room. If it's a child, sometimes we'll have the parent in the room. But usually, patients feel comfortable with this. They've discussed it with a number of different team members, and they know that it's a relatively non-invasive, basic procedure. And I think it freaks people out. It's like a weird experience, but it's not painful, and there's very limited risks. But we really don't allow family members to be present, just because the family member might become upset if they see that they might not understand that the effects of the medication is supposed to make them have trouble speaking. So it can be like sort of an emotional thing for a family member to see. But usually the family member is there just waiting, and we give them an update once it's done. Okay, so then after we ask those awareness questions, we do a spontaneous recall. I think I already mentioned that, to see if they can remember any of the objects or pictures that they saw. Usually they can't remember any of them spontaneously. And then we do recognition memory testing. So when we think about memory testing, spontaneous retrieval and spontaneous recall is always challenging, more challenging than recognition memory. So if you guys think about in your daily life, if you're ever trying to remember something, and then maybe you need some kind of cue or hint or prompt, like if you look at your calendar, or if you say to someone like, where were we when we were talking about blah, 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 and then it kind of sparks your memory. So recognition memory is like that spark, and kind of help you remember better than just retrieving it on your own. So the way that we do the recognition memory testing in the WADA is we actually show them the same objects and pictures that we once showed them, and they have to tell us yes or no for each object and picture. So there's targets and foils. So we intersperse them, we present them randomly mixed up, and they have to, for each object and picture, they have to say yes or no, whether they remember seeing it. Then we take a 30-minute break, and then we repeat the same procedures with different items, of course, on the other side. So if we injected the left hemisphere first, then they injected the right internal carotid for the second side, and vice versa, obviously. And then can an fMRI be done while performing a WADA test? You can't do an fMRI while performing a WADA test, no, but fMRI is actually sometimes a procedure that's used to lateralize language functioning in place of a WADA in certain places. Have you seen cases where someone's immune to the medication? I have seen cases where nobody's immune to the medication, but as I said, some people require a higher dose, and sometimes the medication is not mixed properly. So I've seen cases where there's really no effect, even though they've been given a huge dose, and then we'll give more and more and more until they're like obtunded and then unable to even participate. And then we have to wait for that to wear off, and then we have to repeat it and make sure the medication's mixed properly. I'll talk about, we can talk about some limitations at the end of the WADA test. And can too much barbiturate damage the brain? I mean, too much of anything obviously can damage the brain, but these medications are short lasting and really not giving enough where it would actually do permanent damage. Are there medications which interact poorly with the injection? Patients are checked to make sure that they wouldn't have any, that they're not taking any medications that would interact poorly prior. Okay, so then so we calculate scores then for the language and memory testing. There's a lot of variability, which is one of the limitations actually of the WADA testing across sites. So It's sort of hard to compare results between sites. Some of the memory paradigms look different. The number of items they give are different. There's no standard, you know, the way that I was talking about how all of our neuropsychological assessments are standardized, everybody's using the same. I mean, there's hundreds of tests, thousands of tests that we have as neuropsychologists, but if you're giving test X, everybody's giving it test X the same way. The WADA is just not the same. So that is one limitation of it. At Lennox, we show 8 objects, 4 pictures, which is a total memory score of 12, and then anything below an 8 out of 12 on recognition is considered a failure. Language testing is out of 20 points, and that's sort of more qualitative. There's not really like a pass-fail. And then sometimes correlation with the neuropsych results can also be useful. Okay, so this is just, sort of reviewing, but so, here, if the left carotid artery is injected, you see here the left hemisphere has little Z signs, like it's asleep. And then they're showing the patient the spoon. So it's like the right hemisphere has to, be the one to process if that's a spoon or not. And then when we do the memory testing, what did I give you? And the patient says nothing. And then you see, this is a different type of recognition memory. This would be, presenting multiple objects on one page, but you can see they're able to identify the spoon there. So then we analyze the data, we write up a report that goes to the team. So let's say that a patient had seizures, and on imaging there's evidence of left hemisphere mesial temporal sclerosis, which is used to be very common finding in left temporal lobe epilepsy, but it's actually, now it's less common because it's sort of like a low-hanging fruit, meaning everybody who had left mesial temporal sclerosis got surgery, and now it's like more complicated epilepsy syndromes that end up coming to us. But let's just, for the sake of it, say that that's someone who comes in with evidence of left mesial temporal sclerosis, and we inject the left hemisphere, and their language score was a 0. Okay, so that means speech. Remember, we're testing ipsilateral language. That means speech is in the left hemisphere. And their memory score was a 12 out of 12. Remember, we're testing the right hemisphere memory, opposite for memory. And then following the, let's say, right hemisphere injection, language was a 19 out of 20, so almost perfect. And the memory score was a 5 out of 12, which is a failure. So that means the left hemisphere memory failed. So what would these results tell us? Does anybody want to type in an answer? What they think these results would tell us for outcome? So I should say, the point of the WADA test is to kind of identify outcomes, to see how would the patient be functioning, as I mentioned in the beginning, if we were to remove that part of the brain. So someone said taking out left hemisphere would result in loss of memory. So let's look again. Okay, so the left hemisphere injection, so the language was a 0, so that means language is in the left, because once the left hemisphere was knocked out, there was no more language. Right memory score is a 12 out of 12. Remember, left injection is right hemisphere memory. So right hemisphere memory was very good. Following the right hemisphere injection, language was very good. Okay, meaning once we knocked out the right hemisphere, the left hemisphere was able to speak just fine. And then the left hemisphere memory, because remember, right injection, left memory, was a 5 out of 12. Okay. So there's a couple different answers coming in, but the correct answer is that there's left hemisphere language and the right hemisphere memory is intact. Left hemisphere memory is impaired. The patient would be at low risk for decline following, I should say, a left mesial temporal lobectomy. Okay. So, so this would be actually very positive. This would be a very good result. Okay, so it means that the left hemisphere hippocampus is really not doing anything, okay? Does that make sense? Hopefully. Okay. So even Hollywood thinks the WADA is cool. So there was a WADA test that's on Grey's Anatomy. So this is like, they're talking about removing, I think they're talking about removing Izzy's hippocampus. And then Derek, I think that's McDreamy, says one of them, it's a common procedure for seizure patients. Removing her hippocampus could compromise her memory. And then they're talking about blah, 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 blah. And then they said, have you done a Wada test? And it actually shouldn't be all capitalized. That's incorrect when people do that. And then I think, I don't know if this video will work. Maybe not. Okay. Too bad. But this was like a video of Izzy. I used to watch Grey's Anatomy, undergoing a Wada. So you guys can always watch that episode if you want. Okay, so this is sort of an interesting case. It takes it one step further. So this was an 18-year-old male. He was ambidextrous, and he has focal impaired awareness seizures, which is formerly known as complex partial seizures. And there, on imaging, there was evidence of a left anterior-mesial temporal lesion. So you can see the lesion on these images. Okay, remember, they're flipped, right? So this is the right hemisphere, this is the left hemisphere. Okay, oops. So the neurologist and the neurosurgeon and the team wants to know, if we take out this lesion, will the patient experience a decline in his functioning? So on neuropsych testing, the patient had average intellect. He had evidence of much stronger verbal skills than nonverbal skills. He had intact attention, processing speed, fine motor speed, executive functioning, and language. So he was doing pretty well, a pretty high functioning young man. And he had a focal impairment actually in visual construction. So, you know, when we think about it, it's a little bit weird because, as we said, this patient has a lesion on the left side, okay? So, you know, you really sort of wouldn't expect to see a focal impairment in visual construction, right? You would expect, usually we think of the left hemisphere as being in charge of language, so we would probably expect to see, you know, more deficits in that. This is an example. So this is called the Ray figure copy, and the patient is given this, and it's a measure of visual construction and organization, and then they're given it again following a delay. And actually it's copyrighted, so don't copy it, but just for the sake of this presentation. This was his copy, okay? So when it was right in front of him, you know, this was sort of the best that he was able to copy that figure. So that's kind of crazy that he's seeing the world like that. So you can see clearly his visual skills are not strong. So his verbal memory, to just talk a little bit more about the neuropsych results. So his verbal memory was intact and his nonverbal recall was impaired. This was his ability to remember that figure. So really no gestalt, meaning no main figure. Oops. I don't know where it went. And you can see like most of the details are missing, and it's barely recognizable. So this is an 18-year-old male, ambidextrous with complex partial seizures, a left temporal lesion. And when we put everything together, so his handedness, the fact that he's ambidextrous, plus the fact that he has this left temporal lesion, and the cognitive testing, meaning that it showed a pretty focal deficit in visual construction and nonverbal memory, suggests the effects of crowding. So this is a phenomenon where, so as I said, most often 90 to 95% of right-handers and 75 to 85% of left-handers or ambidextrous patients have dominance in the left hemisphere. And we also call that eloquent cortex. However, let's say that there's a lesion or a tumor or a developmental congenital abnormality or something in the left temporal lobe, in the left, well, yeah, mainly temporal lobe, or left hemisphere, that is occurring like very early on. We live in such a language-driven society that language skills are much more important, just because of the way that our society is, than visual skills. So often what can happen is, this is where the language and the dominant hemisphere would be, but there's this lesion that's interrupting the abilities from forming there in that cortex. So what you actually can see happen is that language and verbal memory and some of these other linguistic skills, reading and writing, can actually develop in the right hemisphere. So they actually migrate over if it happens developmentally early enough. And that means that there's no room then. It's too crowded for visual spatial abilities, which, again, whether you agree or don't agree, visual spatial abilities in our society are just not as important because we need to be able to communicate with, we need to be able to read and write, etc. So visual spatial abilities actually get pushed out, or they might, they might be in the left hemisphere, but again, that hemisphere is not functioning that well. So this is a phenomenon called crowding. So it's all theoretical, okay? So someone said, when it develops on the right hemisphere, does language and verbal function the same? I'm not sure if you mean, do they, I'm not sure what that question means exactly. If you want to retype while I keep going. So if, so theoretically, we were thinking in this case, maybe there's crowding. Maybe the left hemisphere dominant functions are actually in the right hemisphere, and that means that his visual spatial abilities have nowhere to go. Or if they go anywhere, they're going to a bad hemisphere. So if his dominant hemisphere is actually his right hemisphere, his dominant hemisphere would actually be his right hemisphere in this case. And even though language and verbal memory are intact, if he would, normally we would think if someone had a left lesion and they were to undergo, someone had a left lesion and we saw that their language skills, their verbal memory skills were really strong, we would be very concerned because we'd say that there might be a very significant decline if we were to remove that part of the brain. But in his case, if crowding is correct, he would actually be at reduced risk following this type of resection because we're hypothesizing that everything's actually in the right hemisphere. A couple questions. Do they work as they did before? Are there any deficits? Well, as you can see in this case, his verbal skills were strong. His verbal memory was within expectation. So, sometimes it depends at what age things start to migrate, and there's so many different factors. So they can be intact or they can be weak. Would this case be a product of time? Had these lesions in the brain caught earlier, crowding wouldn't occur and thus a better outcome? So not really. I mean, so it's not that he has such a bad outcome because he actually has pretty intact functioning overall. If he didn't start having seizures, I cannot remember exactly when he started having seizures, but I'm assuming he started having seizures and, then since he's so young, they probably did an MRI relatively soon and found the lesion. So without having any seizures, there would have been no reason to suspect that he had a lesion if he was asymptomatic. So, people don't go around just getting MRIs for the sake of it because you would basically be getting, nobody would be, it would just be a waste of time and money. So, it's not really something that you would have been able to catch earlier. So I don't even know if it really makes sense to think about it that way. And in terms of outcome, remember, we're thinking if the crowding hypothesis is correct and we're able to remove the lesion, he actually won't experience such a decline. So the outcome actually might be good. Yeah, and someone again asked about significant changes. So again, it depends. It depends on what age the lesion occurs. If it's very early on, then basically the right hemisphere might just be the entirely dominant hemisphere and you really won't see much of an effect. But, somebody who's young and having recurrent seizures, they're at greater risk for developmental disability and delays and things like that. So they might have other things that are impacting their functioning. Okay. Any other questions? Is this sort of clear, this case? So, again, as I said, the crowding hypothesis in this case is sort of just theoretical. That's what we think is going on. And there's the question, is there a way to confirm that this is really the case? And yes, we can do a Wada test on this patient to try to confirm the crowding hypothesis. So in this patient, when the left hemisphere was injected, his speech was intact. Okay, so remember, we're testing ipsilateral, same side for language. So since we injected the left hemisphere, that was knocked out and he was still able to speak. That tells us that his language is actually on the right. When his right hemisphere was injected, his speech was disrupted. So we knocked out the right and we found that his speech was disrupted, meaning there's not that much language support on the left. So we had right language representation, which is wonderful. And then when we looked at his memory, he had significant left hemisphere dysfunction and intact right hemisphere function. So we basically confirmed that his right hemisphere is the dominant hemisphere that has intact memory functioning and language support. So he would be at reduced risk following a left mesial temporal resection. So this was a really fascinating, interesting case where the Wada was really useful and the neuropsych testing was really useful, and we were able to, let everybody know that he would be at, of course, there's always complications with surgery, but from a cognitive perspective, this patient would be at reduced risk, which is very important because he's a young man. You don't want to really mess him up. Any questions on this case? Okay, I'm going to keep going. All right. So this is a picture of Dr. Bookvar. You guys, I'm sure all know, doing an awake craniotomy from last Tuesday. There's me squatting next to the patient. So in awake craniotomy, I'm not sure if anybody's really talked about this to you guys yet, but it's a type of brain surgery where the skull is temporarily removed to access brain tissue. And somebody asked what complications arise with these surgeries. Do you mean awake craniotomy? Wada is not a surgery. Wada is a procedure. I'm not sure if I want to clarify, but I'm going to keep going. So during the craniotomy, the patient is actually woken up during the procedure, which sounds crazy because they're actually awake while their brain is being resected. It requires an experienced neurosurgeon, a neuroanesthesiologist, and then a neuropsychologist. So, usually the goal from the surgeon's perspective and from the whole team's perspective is to remove as much tumor as possible, but for it to be as safe as possible. And if the tumor is near a part of the brain that controls important functions like language, speech, or motor functioning, then the awake craniotomy is the best way to ensure preservation of these functions. So this enables immediate feedback during the surgery, because while you're operating on the person's brain, you don't have to wait and resect, and then wake them up again and see, did we mess them up? Did we sort of, interfere with their functioning? And this type of surgery, someone's asking about medications. Honestly, those are questions for the anesthesiologist. I don't know exactly what medications and when they give them. So, you could look that up, or if you know any anesthesiologists, you could ask them. So it's frequently used for gliomas, glioblastoma, and astrocytomas. And they tend to occur because these kinds of tumors, so gliomas tend to occur in the frontal and temporal lobes, and that's where a lot of our language and motor functioning are. So that's why those are often the patients who we see. So a lot of people ask if it's painful, and the brain tissue itself doesn't have any pain receptors. So nobody's going to be able to feel the surgeon actually removing the brain. There's a lot of, obviously you have to make sure that the patient's head does not move at all. So there's pins that are sort of throughout the brain holding the patient's head in place, and they're sort of in an uncomfortable position because they're sort of tilted and like the table's tilted and they have to be strapped in. So a lot of times they'll report, you know, some patients will report pain. I don't know if you guys watched the Netflix series, but one of my awake craniotomies is, I think it's episode 7 with patient Christy. She's young. I think she was 16 or 17. And she was actually reporting a lot of pain. It was really hard to do, to get her to, you know, to really participate because she was experiencing so much pain. But she was so young, and, you know, people react differently when they're younger. So we were able to get her to talk, you know, just enough that we were able, you know, Dr. Langer was able to do what he needed to do. And then we put her back to sleep. But a lot of patients feel pressure or they feel pain at where the pins are. And then, you know, if certain parts of the brain are being stimulated and it's near like sensory areas or motor areas, they might get like funny feelings throughout their body. But the actual surgery itself is not painful. Someone asked, how does a surgeon avoid seizures when stimulating the cortical surface with a stimulator? That's a good question. And sometimes if the patient is high risk for seizures, they'll sometimes have electrodes on in the brain as well, on the brain tissue or on the scalp, and they'll be reading the EEG while we're also doing this. I'm not sure if some of the medication that's given to some degree lowers seizure threshold, and obviously, you know, we have them take their anti-epileptic medications. So seizures are not, they're not super common, but of course they can happen. And usually when they do, they're sort of smaller seizures, and we can see them electrographically, and then we just wait a little bit. But yeah, it can definitely be an issue if the patient has a lesion and they are having seizures. It's something to take into consideration. That's why some surgeons actually don't really stimulate the brain area. I'll talk about different approaches. Every surgeon sort of has a different approach. Some of the surgeons really want to map it out and do standardized testing while the patient's awake. Some of them just want to sort of be resecting and not stimulating. So, you know, some of that is the surgeon's preference. How can the surgeon, so we're going to get to actually what's done. Okay. So yeah, so we talked about how the patient can feel the pins, and the neuroanesthesiologist can adjust medications as needed to improve comfort. So sometimes, you know, if the patient's telling me they're experiencing a lot of pain, I'll let the anesthesiologist know. They can always try to increase some meds. So what do we do when the patient's awake? So patients usually awake for 45 minutes up to a few hours. Depends on, you know, the surgeon and the approach and how big the lesion is and where the lesion is and how old the patient is and so many factors. I've sometimes done, you know, there was one surgery at NYU when I was a fellow, and it took like 5 hours. It was insane. Really long. And then other ones are pretty quick. And so sometimes, as we talked about, the patient will stimulate part of the brain near the lesion that sort of mimics that part of the brain being inactive. And as I said, you know, that's probably, you know, the way most surgeons are trained, but some will actually not really do that. They'll just sort of be resecting and then just have you sort of be talking to the patient while they're resecting. And then at the same time, okay, someone's asking about local anesthetic. Yeah. You know, again, throughout the procedure, medications can be given to help with the pain. The scalp has pain receptors, so how do you control that pain? Again, they've been under anesthesia. They're not, you know, they are given still a lot of medication for their pain. You know, the scalp at that point is already open. They're asleep for the actual craniotomy. So they're asleep when they cut open the scalp, when they remove the skull, when they open up the dura, and they expose the brain, that they're all asleep for. And then it's once the brain is exposed that they'll wake them up. And again, they're not they're not like normally, functioning like you and I right now. They're under a lot of medication that can, that still is going to help with the pain and regulate the pain, and they can be given more pain medication if they need. Again, it's a lot of time it's just uncomfortable and pressure and sort of, like if you imagine you're on like, maybe you're on your arm and you're getting like pins and needles and you really can't move at all. So if you're uncomfortable, you can't move. That's more of like a common complaint than real pain. Is just discomfort or pressure, usually. So right before stimulation, if that's what the surgeon is doing. Okay, sorry, one other question, but I'll answer the question in a second. We'll have the patient count or recite a song or like a well-rehearsed phrase or passage. Sometimes we have them recite like the Pledge of Allegiance, right as the neurosurgeon's going to stimulate. And then during stimulation, we usually provide auditory comprehension, auditory naming, and visual naming. So we'll do that, a couple of them with each stimulation of that part of the brain to say that then that part of the brain is clear, because, language is obviously sort of complex. We need to be able to understand, we need to be able to produce speech. So auditory comprehension tasks that we give are things like, we'll say we have a bunch of different items that have been standardized. They're brief sentences, and you'd say like, she sipped soda through a, and then the patient would have to say straw. So they'd have to understand what you were saying and be able to retrieve and produce the right word. And we obviously are looking to see if there's any paraphasias, meaning like if they're saying straw instead of straw, or, if they're saying sip soda through a lid rather than straw, that would be a semantic paraphasia. So we're making sure that they're saying the word clearly, that they're not dysarthric, there's no paraphasias, and that they're providing the response quickly. And then auditory naming, example, you might say an instrument or drum. So same thing, we're seeing how quickly they can do it, that they do it automatically, etc. And then we also would present visual objects, and they'd have to name that object again quickly. Okay, so someone said, in regards to time, when would the elapsed time during the surgery be considered dangerous, or is this just determined case by case? Some of the surgeries take a really, really long time. It's not really that it's dangerous, as long as all the patient's vitals are okay and, there's a reason to keep going. At a certain point, it might become tiring for the patient to be awake, but, it's probably not really dangerous. What would you do if a deaf patient has an awake craniotomy? That would be really, really challenging. I guess you would have to work with, someone who knows sign language, but it would be really hard for them to sign because they're so cramped. But that's a really interesting question. I'm sure it's been done before. Is a patient's accent an issue in language testing? Accent's not so much an issue, but obviously if English isn't their first language and they're using another language normally, we probably want to test them in the language that that they're most comfortable in. Or, we'd want to test them in the language that they don't want to see as much of a decline. So someone similarly asked if patients are bilingual, would you test them in both languages? Theoretically, you would. You would try to do that. You'd probably evaluate which language was most important for them to maintain. Okay, I'm gonna keep going just because I want to show you guys, we only have 10 minutes, and I wanted to show you guys a couple of videos, and then if there's some questions at the end, you can always retype them to me. Okay, so if a patient has any interrupted speech output or impaired comprehension, this means that that area of the brain is vital for language functioning. And this can help guide the surgeon's plans. They may move away from that area, or they may be, not as aggressive in resecting that area. And remember, it's always a cost benefit. So you want to remove as much of the tumor as possible, but also preserve brain functioning. Other things that matter are like the pathology of the tumor. If it's, a higher grade, you might say we should remove a little bit more. Also the patient's age. If they're younger and high functioning, we tend to want to be a little bit more conservative with what we remove. So there's a lot of different factors. Oh yeah, so I was supposed to try to insert the scene from the Netflix show, but you guys can watch that. I forgot to insert it. But here are some pictures. You know, oh, this is actually a video. Let's see if this will work. Can you guys hear this? Because I know last time the, okay. So I'm asking him if he has any pain. He said he's feeling tight, so that's sort of like the pressure. So this is like just when he's sort of waking up. And there's Dr. Bookbar. And then he started to say that he was feeling pain on the left side of his brain, actually. So it was probably from one of the pins. And you can see how you know, how tight it is under there. The setup is always sort of challenging. The patient's head is all the way back here. But he was actually very alert, easily arousable. So Dr. Bookbar doesn't always stimulate, so I just am basically talking to this patient about various things. We still do a baseline testing where we'll do the auditory naming, the visual naming, auditory comprehension, so that we make sure that we have, you know, all that material if needed. But usually with Dr. Bookbar, and I'll always ask the patient certain topics of interest. Because no matter what, even if you're doing the standard stimulation awake craniotomy, at some point the surgeon will usually ask you to just keep them talking as they're resecting, just to make sure that, you know, that things are still going okay. So it's always good to have like a few topics that you can easily talk to with the patient. Hold on, I'm not sure. I wanted to try to show you guys. I hear a couple of oh no, these are videos still. So he was talking about his pool in the backyard, that his kids don't use it. He was very easy to talk to, I think. So there I'm actually doing some of the standard testing with him. Dr. Bookbar is not stimulating, but we're just doing some of the more standard testing at the end. And he really did well. He had no evidence of any comprehension or speech output difficulties, no stuttering, no hesitation. His language remained intact throughout. So that was really, really great. And it was pretty quick too. One more video. I don't know if you guys can hear him, but he's getting them really quickly. You know, it's obviously loud, and I'm pretty far away, and I'm wearing an N95 mask too, so it's makes it a little bit harder to hear. Okay, so you guys get the general gist of it. There's a few questions. How are we doing for time? We have 4 minutes. So I'll try to answer as many of your questions as you can. Okay, so let's see. Are there residual effects that occur due to cortical stimulation? There's not really residual effects, obviously, as we talked about. You can sometimes, in someone who has a lower seizure threshold, that can sometimes result in seizure, but there's not any residual effects that can occur. Does testing ever lead to brain damage or deterioration in language processing abilities? I'm not sure if you mean because of the stimulation itself, but no, there's not evidence that the stimulation itself can lead to brain damage. Are there complications? So there's obviously complications with any brain surgery. There's risk of stroke. There's other risk factors that are, of course, discussed with the patient prior. There's no real risk to waking the patient up other than if it's a really negative experience for them, or if you have a really hard time waking them up. One time there was a patient who I saw an internship at University of Florida, and even at her baseline, she was really, really impaired. She could barely, function. She had really high grade GBM, and we really didn't know why they wanted to do an awake craniotomy. It was kind of like pointless because she was, had such a poor prognosis and was so low functioning. And actually, when they tried to wake her up, she was totally obtunded. She couldn't wake up. So, that can sometimes happen. Can the patient sense, experience bleeding or complications during the surgery before the surgeon? I've never heard of that happening, where the patient is aware of something before the surgeon because they're awake. They might just feel, discomfort and unpleasant. What's the main reason for performing the awake craniotomy in this video? So this patient had a recurrent, I should have talked about his history, but he had a prior lesion in the left frontal parietal area that recurred, and it was near language areas, so they wanted to. He was a young guy, I think he's like 45 or something like that, so they wanted to make sure that they did this surgery awake and that they resected as much as possible, but preserved his language functions. Do patients with anxiety ever present with complication specific? I mean, if there's a patient who has severe anxiety, then this really wouldn't be recommended, or they'd have to undergo like a lot of counseling to really prepare them, because anxiety can definitely play a part in this and make it much more complicated, much more unpleasant for the patient. And if they're unable to participate in the testing, then there's really no point in waking them up. So yeah, sometimes a patient will be, and the same thing goes for the WADA. A lot of times we have to really counsel and work with patients to get them to a place where they feel comfortable with it. Can patients choose to stay awake during the closure? No, you really wouldn't want to, and you really can't make that choice. There's a couple more questions. I'm sorry I didn't get to everything, but I think we're out of time. You guys can email me your questions, tweet me your questions, Instagram me your questions, whatever. I'm glad we got through all of it. I was concerned.
Great. Thank you so much.
Thank you so much. Oh, sorry, I think I missed a lot of questions, but just email me. I'm happy to respond. And squeezing in a Wada and Awake Craniotomy in an hour is tough. So that's why, if you guys have more questions about details, feel free to email.
All right. Have a great day. Thank you so much.
Okay. Thanks. Bye-bye.